going. That's all the housekeeping bits. The Pituitary Foundation, if you're not familiar with us, we provide support for the 70,000 plus people in the UK who are affected by disorders of the pituitary gland, as well as their families, friends, and their support networks. And we want to ensure that every person affected by a pituitary condition has a timely diagnosis and access to high quality treatment, information, and support. We've got a dedicated nurse helpline that is free for anybody to call. We've got online and print resources, most of which are free, and we work with leading medical experts, including Saurabh, to improve patient care. And this event is part of our Pituitary Awareness Month programme. We've got 38 events, talks, social events, so please do check out our website to find out more. But for now, I'm going to hand over to Saurabh, who is a consultant adult and paediatric neurosurgeon in Sheffield, and he specialises in pituitary surgery. He is also a brilliant trustee of the Pituitary Foundation, and it's fantastic that he can join us here this evening. So hello and welcome.
Thanks very much, Ren. I'm glad there's not a lie detector online. I'm not quite sure how best to run this, and I felt that we did a session in Sheffield a couple of weeks ago, or it may only been a week ago, where it worked much better as a question and answer session. So if people want to raise their hands and ask questions, I'm happy to take them. If you are too shy to ask questions, my specialist nurse has given me 25 or so questions that she thinks people like to know about. So before I start, has anybody got any questions they want to ask? Don't all rush at once.
To warm us up, Saurabh, would you be able to tell us about how you've got to where you are now?
If you like. The problem is I have the gift of the gab. I could just keep talking about that forever and you'd be in real trouble. We'll
rein you in.
Yeah, I left medical school with no intention of being a surgeon whatsoever. I liked kidney medicine and I wanted to be a renal physician. I didn't particularly like surgeons. I'm not sure I've changed my mind. And I ended up doing neurosurgery because I ended up working in Edinburgh in the neurosurgical unit, which is my hometown. And I loved the patients. I absolutely loved the patients. Interestingly, the first operation I saw, I thought was one of the most hideous things you could do. It was a lady who was having surgery awake, and they were drilling a hole in her head and frying a part of the brain because she had a tremor. And I could not believe that this sort of barbaric thing was being done in front of me. And the next day I went to see the lady and she said to me, Saurabh, it's the first time in 20 years I've been able to drink a cup of tea without a straw. It was just absolutely amazing watching this poor woman who had such bad tremor in both arms, unable to look after herself, to literally the next morning being able to dress herself and get out of bed and have a cup of tea. I just thought it was incredible. But it's the patients, it's always been the patients, it's never been the operation. I don't know what it is about neurosurgical patients. They're brilliant, and pituitary patients are fantastic, usually because they know more about their stuff than most of the doctors. And so that's always quite fun and really good for the trainees. I have a real interest in training. And so having trainees in clinic where patients can actually tell you what's going on and just are so knowledgeable, it's just great. I love it. I'm always very sad when someone comes into the pituitary tumour that doesn't need an operation.
Fantastic. It's a good place to start.
Yeah.
Before we begin, does anyone have surgery scheduled and have a date for that that's imminent, or is it more of a general interest conversation? If anybody's got a date booked in.
Hi, Jenny here. I don't have an actual date, but I'm told it's going to be within the next 3 weeks.
Fab. Okay. I think that's really helpful to know. And Jenny, you might have some particular questions as we go through, and please do add them, say them out or put them in the chat bar.
Okay, thank you. I'm just learning how to use the system.
Can I go through?
She's gone into robot mode, as we promised.
No worries. We get quite sorry. Some of the questions, if you can hear me, that we get on our helpline are people who are preparing for surgery. Can you tell us how long is the operation likely to take? That might be a piece of string question.
So I always find that question quite funny, because the patient's always asleep. So I always wonder why they're interested. But in general, it takes us about 2 or 3 hours actual operating time. But what that doesn't take into account is the fact that it takes about an hour to prepare you and get you off to sleep, and then a couple of hours to do the operation, and then somewhere around half an hour or so to wake you up and recover you, and then you go into recovery. So we have, in Sheffield, we have a 9-hour, what's called a 9-hour operating list. So starts at 8:30, finishes at 5:30, and in that time I'll do 3 operations. So, but that includes the putting to sleep, waking up, and coming out of theatre. So the whole process takes about 3 or 4 hours.
Brilliant.
So if somebody comes into hospital, even the first person on the list, I always say to their family, it will be midday before I call you. And so that first person doesn't get a phone call till about midday. So just to give a rough idea. I think probably more important is how long you're in hospital for. So more and more places, certainly in Sheffield, it's almost automatic. More and more places doing on the day. So you come in the morning for your surgery. You'll have your surgery that day, and then you'll go home sometime over the next few days. And again, that really varies on where you are in the country and what operation you're having. If your operation is relatively straightforward, you should only be in for 2 to 3 days. We've got a real drive in Sheffield to push to get people home the next day. So most people only stay one night. And we're able to do that because we've got a brilliant endocrine nurse set up. So that if there are issues with too much thirst or peeing too much, or if you're not quite right, then we've got dedicated endocrine nurses who are available Monday to Friday during the day. The ward staff on the neurosurgical ward are available 24 hours a day. My secretary is just about the most amazing person in the world and knows the answer to every single question. And of course, they'll all find me. I'm never that far away if I've operated. So in Sheffield, most people go home the next day unless they've got Cushings.
Great. And what can patients do in advance? So before they're coming in on the morning, kind of recognizing it's a bit of a wait, what kind of things can people do in advance or bring to hospital with them?
So that's a really good question. And the problem is I'm probably the worst person to answer that. And I really had hoped my secretary or my specialist nurse had been on, because she probably does know the answer to that. If you're going to be in for a while, if for some reason you know you're going to be in for a few days, and it doesn't necessarily matter whether that's pituitary surgery or not, bring a book to read or something to do. When you're in hospital, the doctors come round once or twice a day. The consultant, he probably comes once or twice a day and spends a couple of minutes. The nursing staff will come and see you several times a day and will do your observations. But for about 12 hours a day, there is nothing going on. You get bored to tears. So bringing a good book, your phone, iPad, something like that to keep yourself entertained. Don't necessarily need specific clothes, but it's always nicer to be in your own clothes than the horrible hospital pajamas that you get. Some people bring their own duvet. They like their own duvet and pillow just because they're more comfortable in it. Don't forget things like your glasses, otherwise you might not be able to read. And if you're bringing in iPads and iPhones, make sure you bring in your charger, because otherwise sod's law will run out of charge just when you need it. So those are the sorts of things that I would recommend. Michael's on the line and has put something in the chat box. I don't know why we invited Michael. He's a dodgy character. He had Cushings and he was in for a week, and he's right. So when we were operating on Michael, he was one of my early patients. We kept people in for a lot longer, and especially if the Cushings results. So for Cushings, very different. I have a very different protocol. And again, it may not be the same up and down the country, but for Cushings patients, we bring them in, we do their operation, and then we check their cortisol every 6 hours afterwards off steroids. And if all goes well, it's really important if you've got Cushings, if everything goes really well, you'll feel like utter shit, if you'll excuse my French. And the worse you feel, the happier I'm going to be. And the reason for that is cortisol makes you happy and it makes you feel good. So if after Cushing's operation, you take all that cortisol away, you feel absolutely miserable to the extent that you'll want to kill me, but you won't have the energy to do it. And the reason I do that is because again is the next pituitary list, which is usually a week later. And I have had a couple of patients where I've taken them back to theatre a week later, and one patient, in fact, I took to theatre 2 weeks in a row just to get their numbers right back down to normal. So for a Cushing's patient, they may stay in for a lot longer if that's what we're trying to do.
Fantastic. Can I also ask a question about diabetes insipidus? Can you drink water, which is obviously particularly relevant to DI patients, even if patients are nil by mouth in advance of the surgery? How does that work? So
you can have clear fluids up to an hour, up to about 2 hours. Some people would say even all the way up to your operation, but most places say 2 hours before surgery. If you've got really bad DI and you're really, really thirsty, we can put a drip up, but actually most people should be on desmopressin, so they shouldn't feel thirsty. So any pituitary patient having surgery should have all their normal tablets in the morning. Okay, so if you're coming in on the day of surgery, take your tablets at the normal time you would, or before you come into the hospital, including your desmopressin spray. There's no reason not to take. So that should stop you from feeling too bad.
Excellent. Again, I've got quite a lot of questions, but if anyone would like to ask anything, do just raise your hand or pop it in the chat bar. And one of the questions that we get asked a lot on the helpline is whether an operation might be postponed, either because of NHS issues or COVID, or what is the chances of that happening? Because obviously you psych yourself up for it a bit.
Yeah, so unfortunately, it is it's the state of where we are now. So again, this morning, I had a pituitary list this morning, I had a pituitary list yesterday because of the backlog. And my day starts with seeing the patient, having a chat with them, consenting them, and then telling them, I can't tell you if you're having your operation today yet. I won't know for another half an hour. So hospitals all have a bed meeting. That bed meeting is done at different times in different places. And only when we get the go ahead will we say that an operation might happen. And sadly, much as we try and minimize it, patients do get cancelled on the day. And that's usually an issue with either beds or staffing. COVID in itself did have a massive impact, still is having an impact. It's rising again. So for all of you who are online, you've got pituitary tumours, get your COVID boosters, please. We've got staff going off with COVID, so clear if there's not enough staff in the day because of sickness, or if you're COVID positive or you're LFT positive, we're not going to do an operation. The evidence shows that if you have COVID infection, we normally will wait 7 weeks before we'll do your operation, unless you have a good medical reason. Otherwise, clearly, if you're going blind from a large pituitary tumour, we're not going to be waiting 7 weeks. But the reason for 7 weeks is because of the massively increased risk of COVID pneumonia, which has a real impact on life expectancy. So if you're well and can afford to wait 7 weeks, that's what we would do in an ideal circumstance.
That's really helpful to know. Some of the other questions about the actual surgery. Can you tell us who is in the room during the operation and what people are doing? I know there's lots of people there.
So when you come in to have your operation, again, things have changed a lot, but most people get put to sleep in what's called the anaesthetic room, which stands for the anaesthetist, and that's where you get put to sleep. And in that room will be the anaesthetist, who's going to put you to sleep, and at least one other person, which is they're called the ODP, the operating department practitioner, and they're there to help the anaesthetist with all the equipment and putting you to sleep and making sure all your lines are in and that you're adequately monitored, etc., whilst they put you to sleep. There may be more than one ODP in the room, and there may even be a nurse in the room too, but usually anaesthetist and an ODP minimum. You'll then come into theatre, and in the theatre, The minimum team will be the scrub person. So in lots of hospitals, that's a nurse. But in Sheffield, just in the neurosurgical unit, for us, almost all of them are operating department practitioners. So they're not nurses. They've gone through a different setup. So ODPs not only do scrub work, they also do the anaesthetic side. So as I've already talked about there in the anaesthetic room, just in Sheffield, we just seem to have ODPs, although we've got one nurse. When I started training in Sheffield, they were most of them were nurses, but more and more of them come from an ODP background now. So there'll be the scrub practitioner, whoever they may be, nurse or ODP. There'll be the circulating practitioner, who's the main support for the scrub person. So if they need to get more equipment, if they need to help with equipment, because the scrub nurse will be scrub, they'll be sterile, they won't be allowed to touch anything that's away from the operation. There's usually one other person called a runner, and that may be a qualified nurse, qualified ODP, maybe a support worker. It's just an extra person who can kind of leave theatre to go and get things, because the scrub nurse should always have somebody else in theatre with them in case there's a problem. So you need at least 3 members of theatre staff, ideally 4, but we're all running on whatever we can get at the moment. So you've now got your anaesthetist, your ODP, plus the 3 team on the scrub side. And then you'll have your surgeon. Your surgeon may or may not have an assistant. In Sheffield, we do almost all our pituitary surgery as a team between surgery and neurosurgery and ENT. So I do almost all my operations with my colleague Shokat Mirza, who's an ENT consultant. And then both of us may have an assistant or a trainee. So a registrar in neurosurgery or a registrar in ENT, or a fellow is the other word that we use for some of the more experienced ones. And that pretty much makes up most of the team. Sometimes we have students, both student nurses, student ODPs, medical students. So there may be more people in the theatre. And every now and again, we'll have company reps. So all the equipment we use, the telescopes, the screens, etc., they're provided by companies. And so sometimes they will come for lots of reasons. They'll come because they've got new equipment to show us and they want us to see it work. Or they may have their own new staff who come to meet us so that they know who we are and what we do and what their team does, so that they can advise us when there's problems. So there can be a lot of people in theatre. Most neurosurgical units are teaching hospitals. So don't panic if they tell you that the trainee is doing the operation. The trainee will not be doing the operation if they are not in an appropriate stage to do it, and they will always be supervised. I have an absolute policy that, as far as I'm concerned, every operation is a trainee's operation. But I will never let them do it without me there next to them. And I'll never let them do something that they can't.
Fantastic. That makes total sense. Staying in the actual surgery, and I know this is kind of an odd question. Can you talk us through what you do? What's the actual processes?
So once you're asleep, you have all sorts of lines in. You'll have a tube in your mouth to help you breathe. You'll have lots of lines in which help give drugs and monitor you, because of course you're now asleep. And when you're asleep, you can't tell someone you're in pain. You can't tell someone there's something wrong. And so all the monitoring is used to make sure your heart's okay, your blood pressure's okay. You have ECG leads on which trace your heart. So all sorts of things which are done to keep you safe. Because much as we don't want there to be a problem, surgery is a traumatic event. Okay? That is absolutely a traumatic event, and your body doesn't like a traumatic event. So I kind of tongue in cheek, I often describe it as saying the anaesthetist is doing everything they can to stop me from doing something bad to the patient. Okay, because everything I do is something that the body doesn't want. Nobody wants a drill at the bottom of their skull, but that's what they're going to get. And so the anaesthetist's role is to make sure that everything is safe for the patient, so that they can withstand the trauma of a surgery and they're not in any pain, they don't feel anything. And more importantly, they don't move. Okay, so paralyzed, because of course you don't want moving if I'm drilling at the bottom of the skull. From a surgical point of view, we will then prep the patient, usually with iodine or some form of antiseptic condition to kind of clean the face. And then once we've scrubbed, so we'll get ourselves sterilized and we'll put gowns on, we'll then drape the patient so that all we actually see, bizarrely enough, is just that bit there. I can't actually see any other part of the patient, just their nostrils. And then we will use telescopes to go up through the nose to do the operation. And as I've said to some of patients over the years, you'll be surprised what we can get up the nose. So a telescope, a drill, and a couple of other instruments, all of which can fit up your nostrils, even if you're 2 years old, which is the youngest I've ever done.
Fantastic. We're going to pause there and just see if anyone's got any questions at that stage. No.
Ah, Michael. Yeah. I thought we banned you from this place, Michael.
No, not yet. Do you still use the wobbins with cocaine on?
Yes, we do.
Yeah.
It's called Moffitt's, and it's a combination of cocaine and adrenaline and some other stuff that I've forgotten. And we still use it. There are some patients in whom you can't use it. If their heart's a problem, we don't use it because it can cause all sorts of reactions. And also sometimes the world runs out of the supply of Moffitt's. So every so often, if we don't have Moffitt's, we just use adrenaline. And and we use it because what it does is it helps to decongest your nose and reduce how bloody it is, how much blood is there, so that it doesn't bleed as much when we do the operation. It's short acting, so by the time the operation's finished, your blood supply to the nose pretty much returns back to normal.
Yeah, it was just a shock when I found out that I had it.
Yeah, I know you're now a druggie forever, Michael. I'm gonna write that on every reference for you.
Cheers.
There is another question kind of linked to that actually, around kind of after event, the nose padding. Does that still happen? Is it still common?
So yeah, it varies. It varies on where you go. So when I was training, my predecessor would put in what were called Mericel packs. So you'd put a pack inside both nostrils, and then you would soak it in water, and it would swell up. Okay. And then you'd remove it at 48 hours roughly, and you would give pain relief before you removed it. But even then, sometimes you could hear the patient scream as it came out because it was small when it went in, but it expands to fill the whole nostril. So it was really painful to pull out. And so we stopped using that. I use some packing called Nasopore, which is dissolvable. So you put it in the nose, you just leave it, and it dissolves over a period of time, and it falls down out your nose. Sometimes it falls into your back of your throat. I promise when it falls out, it's not your brain, it is just the packing. And we also send people home with a saline spray. It's just salt water, but you can use that to keep the nose hydrated and washed so it doesn't get too dry, because most people complain of a really dry mouth because their nose is blocked. But if you use the spray, 4 times a day, 2 puffs, that usually helps. And then the nasal packing will eventually disappear. We've got a few people where the nasal packing takes ages to go away, and sometimes we end up seeing them in clinic and just washing it out. But for most people, it disappears on its own.
Fantastic. We've got a question from Jenny.
Hi, yes, it's maybe quite sort of specific to myself, but I've got Cushings, and I also have sleep apnea.
Yep.
And I've got a bit of a thing about my mask allows me to nose breathe only and not mouth breathe.
Yeah.
Well, I think I can mouth breathe actually, but I nose breathe, and I'm a bit worried about how that will pan out with my nose being packed.
So your nose doesn't have to be packed. So one of the options is they don't pack the nose. Are you having it done in Scotland, in Glasgow?
In Aberdeen.
Aberdeen. I mean, you can speak to them about whether they have to pack your nose. But even if they do pack your nose, you'll have no problem breathing. Trust me, you'll switch to mouth breathing.
Okay.
But also the packing's put in such a way that it shouldn't block the floor of the nose, which is the bit that you breathe through. So you can
Right.
packing and still breathe through the nose, but it just seems a bit uncomfortable. But you'll be perfectly happy mouth breathing. We have lots of people who have sleep apnea and CPAP hoods, etc., who don't have a problem. I'm sure it's a little uncomfortable, but no one, everybody's breathing fine.
Okay, that's great. Thank you.
Brilliant. Is it common to have headaches after surgery, Saurabh? Are there any other side effects?
It's funny, isn't it? I mean, I didn't think people would necessarily get headaches after the operation. I couldn't even necessarily understand why, but actually most of my patients all say that they get a feeling of a headache just here, bang in the middle, just above their forehead, probably not far from where I've been. So yeah, it's not uncommon. For most people, it's not horrible. It's just they feel like they've got a dull headache and they need pain relief for it. I've had a few who say the headache's awful and a few who've said the headache's not too bad. So I do think the majority of people have some sort of a mild headache, literally bang in the middle of their forehead. So don't panic if you get it, nothing's gone wrong. Make sure you ask for pain relief if you need it.
Brilliant. Are there any other kind of likely effects that patients might expect?
So for me, the biggest thing is the recognition that this is a major operation, okay? And one of the difficulties that I often find when I see people in clinic or during the time afterwards is they tell me that they don't understand why they're so tired. And the reason for that is because when you get looked at by other people, they cannot see that you've had anything done. Everything is hidden inside the nose. Everything. There aren't any scars outside. And worse than that, the patients only see no scars. So they think they've not had anything done. So then they don't understand why they're tired. Oh, I should be able to do my 6 weeks shopping, look after my 3 kids and run a marathon. You know, it's not. You've had major surgery. And if we'd done this the old-fashioned way, so before my time and probably before everybody's time on screen, you'd have had a cut from one ear to the other. We'd have taken the skin down over the forehead and we'd have opened your forehead to get underneath the brain to the pituitary. What we've done is we've just gone up through the nose and we've hidden it all, but we've still gone to your pituitary gland. You've still gone through the effects of having a general anesthetic. You've still had a 3-hour operation. And we've still messed around with your pituitary, which is pretty helpful for keeping you feeling normal. So every right to feel tired. And I think my biggest issue is my patients don't believe it because they look in the mirror and they just see themselves. So please don't be surprised if you're tired. If your Cushing's operation goes well, Jenny, and your cortisol levels are low, you'll feel utter crap and you'll feel crap for ages. Even when we give you the steroids back, you'll feel crap for ages because patients with Cushing's have a really, really high cortisol level. And that's not what we're going to give you back when we do the job. That's the whole point. So you do feel really tired, but everybody does. And my routine is to give people 6 weeks, a six-week sick note when they leave, if I remember. I often forget. And when I see people in clinic 6 weeks down the line, the majority of them tell me that they feel ready to go back to work or whatever activity they were doing before. A small number say, God, I felt so much better. I was bored. I went back to work after 2 or 3 weeks, although that's rare. And then equally, there's a rare number who say after 6 weeks, I'm still nowhere near ready and they just need longer. But the majority of people are ready to go back to work or normal activities about 6 weeks down the line.
That's really helpful. And in the shorter kind of time after surgery, could you expect to get out of bed, have a shower, you kind of move around?
Well, I'm trying to send everybody home the next morning, or the next afternoon, so as quickly as possible.
Pretty speedy.
Yeah. Unless it's a complication from surgery, I would be expecting most people to be up and out the next morning, out of bed, up and about. And as I said, so I did 3 operations on Sunday. 2 of them have already gone home, and 1 I've kept in. But yeah, and the other thing, to a large extent, I apologize, I can't see people's faces. I've no idea how old anybody is, and I don't mean to be rude. But if you're over the age of 80, you go home quicker than if you're under 40.
Why is that?
Because 80-year-olds don't complain. 40-year-olds whinge like hell. So my fastest people leaving were 87, 81, 84, and 85. They just do not hang around. And I think there's two reasons for it. One, because they don't hang around. And two, I'll just give you an anecdote. He was one of the first patients he was the first patient I operated on who was over 80, and I was scared. I was thinking, oh my God, am I doing the right thing? And I was doing the right thing, but you worry about it. 81, lovely man, Ron, he won't have a problem about me talking about him because he was all over the newspapers. And he had surgery, he was home at 48 hours. I told him all these things, you know, take a rest, be careful, do what you do. I got a letter from him on the Monday which said, you're not going to be very happy about this, but I was playing golf on Friday. I thought, are you joking? Only did your operation last week. And he said, I know you won't be very happy, but I'm 81. I don't know how long I've got to live. And I can see now since your operation, and my handicap's so much better now, I can hit the ball. So that was his attitude, is I don't know how long I've got and my vision's much better, so I'm getting on with it. So yeah, I just believe that the 80-year-olds, they want to get on with life, and they do, and they're amazing. I love looking after them. The under 40s, I'm really sorry, but you whinge too much.
We've all got things to learn. Yep. Janet's just put a comment in the chat that it is all very different from her operation in 1965 to how it is now, and things have changed so much, haven't they?
I hope so.
Will they continue to change? Can you see how surgery is going to continue to evolve and become more efficient, less invasive?
I mean, surgical techniques do change, and oh God, I really hate that I'm going to have to say this, but the biggest reason why we've been able to do things is anesthesia and the ward care afterwards. They're the ones that make the big difference, because, you know, if you can put someone to sleep easier, if you can wake them up quicker, if they're in less pain and less traumatic, they get up and about quicker. The ward staff are incredible. They just learn to manage to do things. So whereas we used to keep patients in for a week while they looked after them, now they can get you all patched up and out the door in 24 to 48 hours. So yes, some surgical techniques have changed to make it different, but to a large extent, I'm going to have to say it's anesthesia. I really hate saying that. I hope none of them are listening. That'd be really bad. But yeah, I think that does make a huge difference. Clearly, you know, Janet's right. There are operations where we would have opened the head, and that does take longer to get over than going up through the nose. Where we can go up through the nose and do that operation, and we can do that more and more than we used to. So yeah, I think there is some element of surgical techniques. Is it going to change much more? There's always little things you can do that can make improvements. And I'm sure technology will come in that will help us see more of the tumor, see more difference between tumor and normal pituitary, so that patients don't have as much pituitary problems afterwards. And then I guess the phrase that's used against all surgeons is, you're only one tablet away from being unemployed. And that's where we see prolactinomas almost all get managed medically. They very rarely need an operation. There are some reasons for operating, but to a large extent, you manage prolactinoma with medicine. And if you can find a tablet that cures Cushing's, I'm sure Jenny would not be lining up for an operation. She would be lining up for a tablet.
Yes. Sarah's asked a question, which I'm sure everyone would be interested in. What are the risks?
Okay, if you don't want to hear how brutal they are, feel free to go turn your speakers off. So the risks for pituitary surgery are because of where the pituitary gland is. Okay, so I'm not having a go at anybody because they're under 40 or they're over 80. It is just because of where the pituitary gland is. And the pituitary gland is located roughly here. And on either side of the pituitary gland sits the carotid arteries, and they supply blood to 2/3 of your brain. The top of the pituitary gland is a small membrane, above which sits the nerves division, the brain and spine fluid, which we call CSF, and the brain. And behind the pituitary gland, behind the lining of the brain behind the pituitary gland, sits the basilar artery, which supplies blood to the bottom part of the brain, which actually keeps you alive. So the simple answer is, if we damage any of those structures, there's a risk to you. So the risks we talk about are, if we damage either of the carotid arteries, there's a risk of a stroke, which would leave you paralyzed down one side or the other and may stop you from speaking, and there's a small risk to your life. If we damage the basilar artery, which is harder to do because there is still a thin wall of bone between the pituitary and the basilar artery, then again, there's a risk of bleeding. That risk of bleeding can lead to a risk of a stroke, which would paralyze you from the neck downwards to a large extent, and a small risk to your life. The basilar artery is usually protected by a little bit of bone. The carotid arteries are not protected by anything. Your pituitary runs right up to your carotid arteries. There is no gap. The roof above you is very thin, and when we take the pituitary tumor out, the roof can get a hole in it. If there's a hole, fluid can leak into your nose, and because we've done an operation through the nose, it can leak out your nose. And you might say, well, what's a bit of fluid dripping a problem? The problem is that you now have a path for bugs to get in, and if the bugs get into that fluid, the infection is called meningitis, and you end up being pretty sick, and you end up having to come back into hospital for a couple of weeks of intravenous antibiotics. And if the leak still persists, you'll have to go back to theatre and have that leak repaired. People panic about meningitis, understandably, I get that, but it's not the same meningitis that you hear about when you hear about children who never make it into hospital, okay? It's a post-operative meningitis. It's still serious. It still has significant risks, but you don't feel as, you're not as sick as those children, but you will be sick and you need to get to hospital. If you have bad headaches and a leak from your nose, you need to get in touch with the team that did your operation as soon as possible. And then there's clearly a risk to the pituitary itself. So if you have a very big tumor, or even if you don't have a very big tumor, we can damage the normal pituitary gland. So you can temporarily lose pituitary function, or sometimes it can be permanent, including a risk of diabetes insipidus. So you pee too much and you want to drink too much. All of those are fixable by medication, but they're still a complication. And then anyone who has a general anesthetic and an operation has a risk of just a general chest infection, a risk of a clot in the legs, which we call a DVT, a clot in the lungs, which we call a P or a pulmonary embolus, and a small risk of a heart attack. And that's there again for everybody. It's a risk of a general anesthetic, doesn't matter how old you are. And in order to minimize those risks is why we try and get you up as soon as possible. It's why you have those sexy stockings that you'll all have to wear, and why most people will get the injection in their tummy about 6 o'clock at night to try and keep the blood thin so you don't get those clots. I hope that answers your question, Sarah, and I can see Jenny's got her hand up again.
Sorry, it's not really meant to be all about me. My neurosurgeon mentioned something about taking some sort of abdominal fat and using as a plug.
Yeah, so okay, so when people do the pituitary operation, sometimes if they get a leak, and sometimes if they don't get a leak, people will repair the bottom of that, and that's done differently by different people. So yeah, my predecessor, when I was taught by him, he always took a plug of fat from the tummy just above the belly button, and he stuffed it in the hole where he made in the pituitary gland. Different people don't. I don't use anything at all unless there's a leak, and even if there's a leak, I have a tendency to use the inside of the nose. But yeah, some people use fat from the tummy. Some people use tissue from the thigh. Some people have even used tissue from the earlobe, although I've never seen that, but apparently some people have. But yeah, the tummy fat is not uncommon.
Okay, thank you. I could donate tummy fat for the whole of the UK if there's a tummy fat bank.
Yeah, no, I've got quite a few patients who say that, and yeah, it's very typical for Cushings. But yeah, no, don't worry. It's a common place to take it from.
Okay, thank you. I'll shut up now.
No, it's all right. If you're the only one brave enough to ask questions, I'll keep answering them.
I'm the only scared enough one.
Following on, Saurabh, from your really clear kind of outlining of the risks, one of the questions that I had was around what you can say to people who are feeling anxious, what kind of reassurance you can give to people in advance of surgery.
Okay, so before I forget, if there is, the Pituitary Foundation do have a video of me talking about pituitary surgery, and I did talk about the risks in that too. And I think I drew some diagrams on scans to show why. So if you're feeling really brave, you can have a look at that. But hopefully I shouldn't have said anything too different on that as I have now. But from an anxiety point of view, my honest answer is, I'm glad. My biggest fear is a patient who is not anxious or not scared, because it makes me think they do not understand that there are risks to what we're about to do. So people who come in absolutely not scared, I worry that they don't actually understand what we're about to do, because it doesn't matter how often I do this. Every time I do it, there's a risk from what I do. And I've been doing it a long time, and I still have risks, and we still have problems, we still have complications. And it's done with the best will of the world, but we still have them. And so I don't have a problem about people being anxious. I think it's a natural response, and it's a sign that they actually understand that there's a potential problem happening. So I don't want to stop you. I do want you to not panic too much, because that doesn't help. But I can't stop you, and I don't expect to stop you from being anxious. A little bit of anxiety is fine, but let the surgeon worry about you properly. That's our job, is to worry about you. You just, a little bit of anxiety, there's nothing wrong with it.
Fantastic. Lottie's just posting those links to the video that Saurabh was talking about in the chat if you want to click on the links. Saurabh, have you got other questions that we haven't covered off that you've been equipped with that you get from your end? I'm
hoping that the first two questions you've all had answered to the best of your ability. And the question was, what type of tumor is it, and is it cancerous? And my first conversation with anybody in clinic that I've never seen before is, and often even before I tell them my name, is, it's benign, it's not cancer, and it's not going to kill you. And to a large extent, that's true. Most pituitary tumors are benign. Pituitary tumors that are cancerous and have spread from the body are almost always in people who already know, because the pituitary is not an early place for cancer to go to. So they already know they've got it. I can't remember ever having a patient coming to me with cancer in the pituitary gland who didn't know they didn't have cancer elsewhere. So it's almost always benign. And the tumor itself very rarely will kill you. Surgery might. I'm not trying to frighten you, I promise, but there is a risk to life. The disease might. So we know that if you have Cushing's disease or you have acromegaly, that condition will reduce your life expectancy if we do not treat the condition. So not necessarily the tumor is causing the problem, but it's the condition that's causing the issue. It doesn't have to be with surgery. For Cushing's, so long as you can bring the cortisol levels back down to relatively normal with whatever you've got, be it surgery, radiation treatment, gamma knife, medicine, having your adrenals out. I think Michael's had almost all of those. And with acromegaly, again, so long as we can get your growth hormone levels down, again, it doesn't have to be the surgeon. It can be by medicine. It can be by gamma knife. It can be by radiotherapy. So long as you get them down, then the condition will, your risk, your life expectancy risk, come back down to normal. So those were the two questions that commonly get asked. Now, often had people, I'm often surprised by the number of people who come into the PIT clinic having all they've been told is they've got a lump in their brain, they're absolutely convinced they're going to die. And so, yeah, I have had a few patients where I've not even told them my name first. I can see from their face that they are just scared, and that's where I start with, and then I introduce myself after that.
Fantastic. Are there any other questions that you've gone through all of mine, Saurabh, and all of the ones that we get most commonly, but I'm interested what your
that's right.
nurse has suggested.
So how's surgery performed? We talked about whether they're packing stitches, that we've talked about who'll be doing the operation. So it's as I said, it's done by a team that know what they're doing, but their trainee may well be doing the operation. And if you're in Sheffield, the trainee's almost always doing part of the operation. How many patients do I operate on a year? So about 50 adults and about 5 kids, roughly. although COVID has caused a bit of a hit one way and the other. How many years have I been doing the operation? As a consultant, 13. As a trainee, when did I do my first operation? About 20 years ago, I think. So about 7 or 8 years as a trainee and 13 years as a consultant. You've every right to ask your team that. As far as I'm concerned, every pituitary surgeon should know roughly how many they've done. They should know their risks. They should know their own risks. So we quote risks in general, but you should know your own risks. I can quote every risk of my own. I remember every patient I've harmed, and sadly, when I retire, they're the only patients I'm going to remember. Are the ones where something went wrong, because they're the ones that I never forget. And Michael, because he's a pain in my ass. Sorry, Michael. But yeah, people should know. They should know roughly their cure rate for Cushings, their cure rate for acromegaly, and their rough complication rate, their CSF leak rate. They should be able to quote that. Sadly, Michael is one of my Cushings not remission rates, but I tried, didn't manage. Sorry, Michael. We've talked about general risk to health. We've talked about complications of the pituitary gland. What pre-op care is needed? So I'm a little bit vague on that one, because clearly that's not the bit that I do. But again, I can talk about Sheffield, and I think most people do this now, is you'll be sent to a preoperative assessment clinic where you'll be seen by a nurse and a doctor, or what combination of both, where they will check your general health for an anaesthetic. And they may take some bloods, they may do an x-ray, they may do an ECG, do all the things they need to do to make sure you're fit for an anaesthetic. Because of COVID, there are all sorts of rules, and that varies from hospital to hospital, and it also varies on how bad the COVID state is in the country. So at one point, we were asking people to isolate for 14 days, having all sorts of tests. I think that's changed recently to 2 or 3 LFTs before, but it does vary from hospital to hospital. So please, will you check with your own hospital if they haven't already told you what the COVID isolation rules are. I'm just going to keep going. So these are the questions that my specialist nurse sent me. Will surgery remove the whole tumour? Will I be cured? Hopefully. Whether you remove the whole tumour or not depends on how safe it is. So if your tumour is wrapped around the big blood vessels I talked about, the chances are we're not taking it all out. To me, the most important thing is not what the scan looks like, it's what my patient's like. And as far as I'm concerned, I want my patients to look as good as they were when they came in, if not better. And if that means my scan shows that I've left something behind, so be it. One of my simple rules is if my patient is well, I can always go back again if I have to. But if I harm my patient, then there's no way back. So it's much more important about doing what's safe for the patient than it is about having the best scan. So I don't always, there will be occasions where I deliberately will leave tumour behind. Do all pituitary tumours require surgery? No. If you've got prolactinoma, you can be managed medically, although some people don't tolerate the medicine, so they might need an operation. And then if your pituitary tumour is small and causing no symptom, then you don't need an operation at all. You can just be watched. So that there's no reason. We've talked about the operation, who's in hospital. Can I blow my nose? No, absolutely not. Can't blow your nose for a couple of weeks after the operation. And the new one that goes with this for me, and I've made up this number, I don't know why, but I'm sticking to it. No COVID test up your nose for 3 months after pituitary operation. You need the whole thing to heal. It would be a disaster if you caused a CSF leak. I'm happy for you to have the COVID test on the back of your throat, but not up your nose, please. And if you feel the need to sneeze, open your mouth so that the pressure comes through the mouth, not through the nose. Thank you, Michael. And there is a trick, which I was taught, that if you stick your tongue to the back of your palate and lick the roof of your palate all the way to the tips of your teeth, it will stop your sneeze. And if you've never done that before, bloody brilliant on the motorway. So when I feel a sneeze coming on, that stops me from sneezing. It's Offie trying to drive when you can't see. So yeah, so those are the big ones. So please don't blow your nose because blood might leak. More importantly, CSF might leak, and then I'll be very upset. Somebody has put something on the chat.
Is radiotherapy common post-surgery?
Not common, but it is. In fact, that was my next question. Will I need further treatment? So radiotherapy is not common because it's a benign tumour, and benign tumours don't do so well with radiotherapy, but it's not unheard of. And we use radiotherapy for patients who have, okay, so let's just go through the tumours again. So if you have, pituitary tumours are in two different flavours, and I apologise if most of you know this. So one flavour is produces hormones, and it produces conditions like Cushings, acromegaly, or prolactinoma, or if it produces too much TSH, you'll get all the symptoms of having an overactive thyroid gland. Or it can be a non-functioning tumour where it doesn't produce any hormone, but its basic size is what stops things from happening. So if it's a non-functioning tumour, it can grow and squash the nerves to vision, or it can just squash the pituitary gland itself, and you get all the symptoms of having an underactive pituitary gland. So you don't have much energy, you lose your sex drive. If you're a female, you may stop having periods if you used to, difficulty with erectile function, and you may lose hair under your armpits, etc. So those are some of the things of not having a functioning pituitary gland. So if you have a functioning tumour like Cushing's or acromegaly, and the surgery hasn't done the job, and the medicine's still not controlling it, then you might have radiotherapy offered to you. And radiotherapy can be done two ways. You can have standard radiotherapy, conventional radiotherapy, which is done Monday to Friday for about 5 or 6 weeks. Or you can, if it's small enough and away from vital structures, you could have a treatment called gamma knife radiosurgery, which is much more focused on the small tumour, but you could only have that if your tumour is not near the brainstem and not near the nerves division. And if you have a non-functioning tumour, and we've had 1 or 2 or 3 or 4 goes at it, or we've had a go and it was really difficult and we thought this is too close to anything vital, then we may offer you radiotherapy to reduce the risk of you needing another operation. I hope that answered that question. And there are more in the chat box now, Ren.
Yeah, there's another one from Natasha about, can you always see a tumour on a scan before surgery?
Oh, so that dreadful condition called Cushing's, which
is what it's referring to,
gives you a really hard time. So no, at least I think somewhere between 10 and 20% of Cushing's tumours can't be seen on MRI scan. Oh yeah, Michael, God forgive him. So Michael, we could
64.
We could see the tumour, but
64% can't be seen now.
No, it's not as many as that.
No.
Well, not. To be honest, that may well be true, Michael. Usually, the ones that come to me, you can see them because I unfortunately have a brilliant Cushing's endocrinologist. He is probably the world's leading Cushing endocrinologist, and he gets all the big ones. And so, being his surgeon is not much fun.
Who's that?
Yeah. So you can see. So Michael, we're going to use you as an example, if that's all right, mate. Michael's tumor, we could see. What we didn't see very well first time around was actually his tumor went into the cavernous sinus, which is the bit beyond the carotid artery and therefore not easy to get to, or if you can get to, there's a real risk of causing a major stroke, a paralysis. So I don't usually invade it. When I did his operation the first time round, I didn't think I could see it. And it was only when we were thinking of going a second time round that the second scan showed there was tumor in the cavernous sinus, which is why poor Michael ran away from me, or maybe I ran away from him, I'm not sure which. And he's had other treatments instead. So yeah, you can't always see the tumor.
Does that answer your question, Natasha? I hope so. Let us know if not. Louise has got a question. I have a non-functioning tumour situated where the optic nerves overlap. I keep getting vertigo and falling sideways. Is this because the balance of my vision is upset?
It's not. it's not something I've necessarily heard of, but certainly if your vision is a problem and you can't see properly, then yes, there's always a risk that you might fall. And there is a risk that it affects the way your eyes work together. And the ophthalmologists are very clever. They talk about hemi-slide field. I don't understand a word of it, but it is a sign of your eyes not working together because the nerves are being squashed. And so that can cause all sorts of horrible symptoms. So whilst it's not common to hear what you said specifically, it's not impossible. And my guess is the only way you'll know is when you take the tumour out and whether it gets better. Does that answer their question?
Let us know if not, Louise. There's no other questions in the chat at the moment. So have you got anything?
So are there worrying side effects, complications to look out, or who to contact if I'm worried or ill? Okay, so that one I think is really important. So if after your surgery, when you go home, you feel really rubbish, and I mean really rubbish, that can happen because although we check your bloods before you go, your blood levels are normal, the pituitary can go on strike a few days down the line, and your salt levels can become really poor, or you might need more steroids. So if you do feel rubbish, pick up the phone and call. So who do you call? You should, before you leave hospital, be given the phone number for the ward that you were on or an equivalent ward that's available 24 hours a day. Most places should have, and hopefully have, an endocrine nurse set up, so a team that you can call, but they're usually only there Monday to Friday during the day. And then the consultant who did your operation, or whose team did your operation, you should get the phone number for their secretary. And again, that's only a Monday to Friday. If you're really sick, pick up the phone, call an ambulance, okay, and tell them you've had a pituitary operation. Warn them that you may need steroids, because they need to make sure they've got somebody who can deliver steroids in the ambulance if that's what you need. If you know you're on steroids, on hydrocortisone, can you please make sure, if you don't already have one, you get yourself a necklace or a bracelet that says I'm on steroids. Can you get one of the steroid cards? The Pituitary Foundation has a wee link for that. And the thing that lots of people have been very clever about, those of you who have a mobile phone, if you put your steroid card on your lock screen, nobody needs to be able to open your phone to see that you need extra steroids. You should all, if you're on steroids, have been given sick day rules. If you haven't, can you go back and ask your team for them? Or again, the Pituitary Foundation will have that for you. If I'm plugging the Pituitary Foundation, there's a very good reason for it. It has loads of information about all this stuff. But you should be given sick day rules, and you should have an injection that you might need to take if you are unable to hold the steroids down and you're being sick. And you need to check that that injection is in date, because if you've not been unwell for years and years, you may find that that injection's out of date and you need to get a new one. For those of you who have children who might need steroids, can you please make sure that the school has an injection as well as one at home, because they're probably going to spend as much time at school as they are at home. I know lots of people who have one at work as well as one at home, and then one spare that they carry with them all the time, so they have 3. Nothing wrong with that. Okay, no one should ever die for not having been given a hydrocortisone injection.
Excellent. And Lottie's putting some of the links there in the chat at the moment. We've also got one more question from Sarah. I've got a 3mm tumour in the pit gland. Will IPSS show exactly where it is?
No, it won't. IPSS is used in patients where you are querying or you're concerned that they have Cushing's disease. So Cushing's syndrome is when you have too much steroids produced. It doesn't necessarily mean it's from the pituitary gland. Cushing's disease is from the pituitary gland. So if you've been diagnosed with having Cushing's syndrome, then an IPSS is done in order to try and prove that or to prove to the best of ability that the the cortisol excess is coming from the pituitary gland. So what you do is they put a catheter up into the petrosal sinus, which is next to you, very next to and close to the pituitary, and then they give you some drugs, and they take some blood from your arm at the same time, and they look to see if the levels in your head from the IPSS are much higher after that drug than they are in your body. And if that's true, then the problem is in your pituitary gland. It does not tell you necessarily whether it's left or right, even though sometimes one side is more obvious than the other. That doesn't necessarily follow. So it's just good for telling you that's from the pituitary or not.
Excellent. Put it in chat if that doesn't answer it, but that sounds very clear. Is there anything else on your list, Saurabh?
So hopefully I've covered the thing about who do you contact if you're worried. I think that's really important. Will I need to take medication potentially, and who will monitor this? Once you've had a pituitary tumor, you should almost invariably be under an endocrinologist for the rest of your life. They are very possessive. They almost never discharge anybody. Me, I try and get rid of everybody as soon as possible, but they never do. When can I go back to work, drive or fly? So again, depends on why you're unwell. If the reason you weren't allowed to drive was because you had a tumor squashing your nerves and you were stopped from driving, then you have to have a test done by, it's a proper test done by the ophthalmologist. There's a driving test thing that you have to pass before you're allowed to drive again. If you weren't banned from driving, or you're told you weren't allowed to drive, you can drive as soon as you feel well enough. You go back to work whenever you feel ready. As I said, that usually is about 6 weeks down the line, but as I said, I've had some who've gone sooner and some who've gone later. And when can you fly? Whenever you like. There's nothing stopping you.
Excellent. Has anyone else got any other questions before we start wrapping it up? It's been totally fascinating and really helpful on a really practical level. It's been fantastic. But feel free to ask any of your own individual questions. We've got Saurabh here.
Just the last question, I'm not quite sure why she's put it on. I guess because people ask it, but I really hope I don't need this group to know the answer to this question. But it's, are there any organisation or booklets or online resources or local groups I can contact? God, I hope you know the answer to that question. If you don't know the answer to that question, we're going to sack Ren.
The Pituitary Foundation, here for everybody. It's free. And
it is. I mean, if you do have anybody you know, it is. I know, and I know that as a trustee, and I am going to be biased, but the reason I joined the Pituitary Foundation was because of the amount of help it gave to my patients, and they all talked about how brilliant it was, and it is. It's a really great resource. Use it. Lots of people. I mean, the other thing is just the local groups. There are contacts for local groups. They'll be on the website. If you don't have a local group, feel free to make one. We're always willing to help you. I'm always willing to come and talk at the local groups. It doesn't have to be mine, so long as it's within a reasonable distance. I hate driving, but I'm willing to do it. But your local endocrinologists and surgeons are all happy to come and talk. The endocrine nurses are happy to come and talk. They are amazing. I've done a couple with my paediatric endocrinologist as well. So we're happy to come and talk, because at the end of the day, we're here for you. That's what we're here for. You know, my common line to my trainees is, we don't have a job if we don't have patients. So if we're not putting them at the center of everything we do, then we're in the wrong job. So if there's things we can do to help, if there's places you want us to come to just try and explain what's going on, very happy to do so. So yeah, please use the foundation and all their members. And if you don't know who you can contact in your region, let the foundation know. Pat will know everybody.
Absolutely. Well, thank you, and thank you so much for sharing your time and your expertise and your insights. It really has been so helpful, and please do, if anyone's got any questions that have kind of come from this which you haven't quite formulated, if you've got questions that evolve over the coming weeks, our helpline is always there and it is free for everybody, or drop us an email. We're all very happy to receive emails. Nothing is too much bother, it really is true. For Awareness Month, all of our sessions should be available online on YouTube in the coming month-ish or so. You can also head over to our social media channels, to our website, to see other sessions that are available, as well as some of the resources. And Lottie's putting links in the chat there. We're really, really pleased to have brought you this month's of workshops and online sessions for free, but we do rely on kind donations of supporters. So if you found the session useful and you're able to do so, please consider making a donation to the Pituitary Foundation to help us continue our work raising awareness and supporting patients. You can do it by text, by texting Living Well 10 to 785 to donate £10, and that's a £10 donation plus one standard rate message, or you can just go onto our website to donate through that. So thank you very much, and I really hope we see you at some other Awareness Month events or at local support groups in the future, and thank you again to Saurabh for your time.
You're very welcome.
See you all soon.